Happy to introduce Dr. Susan Ritter. Today, Dr. Ritter will be talking about soft tissue syndromes. Dr. Ritter, thank you.
Thank you so much for having me. As Dr. Della-Ripa said, I'm here to talk about soft tissue syndromes. Here are my disclosures. And I'm going to talk today about several regional pain syndromes, starting at the shoulder and working our way down to the ankle. And towards the end, we're also going to cover generalized soft tissue pain, also known as fibromyalgia. So to get started, I want to go through some definitions so that we're all on the same page. So these are multiple different things that can contribute to soft tissue pain. You have tendons, and tendons are the collagenous portion of a muscle at its origin and insertion. So you have tendons right where the things attached to bones, but you can move your skeleton. You have the enthesis, which is where the tendon is attaching to the bone. That's a separate structure. There are also bursas, and bursas are two membranes and the lubricated space between that allow for the near frictionless motion of soft tissue over bone. So often you will have bone, and then you'll have a bursa, and then you'll have a tendon or an enthesis in that general region. And all of these can contribute to soft tissue pain. There are also ligaments. Ligaments are the collagenous tissue that connect two bony structures. These don't really move much. They're holding things in place. And then there's also the fascia. And the fascia is a layer or sheet of fibrous tissue that separates or covers these various soft tissues and organs. A few more definitions that will help us as we go through are a sprain is an acute traumatic injury to a ligament versus a strain, which is an acute traumatic injury to the muscle tendon junction. And this may be also called a pull. So a pulled muscle would be a strain versus a sprain, which is in the ligament. There are also overuse injuries. So there may not be an acute injury that the patient recalls, but maybe there's sort of chronic, repetitive microtrauma going on to the soft tissues that can contribute to this overuse injury. So when we think about tendinitis, what you're trying to elicit from the history is pain with active motion. There may be weakness associated with that pain because they don't want to move it because it hurts. And as you're taking the history, you want to try to get an overuse history. Maybe somebody is lifting their arms a lot to put things on a shelf and putting their arms over their head, and that is contributing to the tendinitis. On examination, you always want to be doing passive and active range of motion. And what you will see with tendinitis is that there is very little discomfort with passive range of motion. So if you do the movement for them, it should not hurt much. But if they try to do it themselves, it will be tender. Also, if you have them isometrically contract the muscle that is linked to that tendon, that should be tender as well. For example, in a biceps tendinitis, you can have them contract the biceps and then it should be tender right over that tendon. And sometimes if you can find that tendon, if you can feel it, depending on anatomically where it is, it will usually be tender. This is in comparison to a bursitis. So with a bursitis, there will also be pain with active motion. As the tendon or whatever structure is going on top of that bursa, it will hurt. With bursitis, weakness is not a prominent feature. It's not like the tendon is linked to a muscle that would normally be strong. So you won't get a weakness history. You may get an overuse history, just like you do with tendinitis. And with the physical exam for bursitis, passive range of motion may be a bit more uncomfortable with tendinitis because anything that moves and puts pressure over that bursa, whether the patient is doing it themselves or you are doing it to them, may be uncomfortable. Isometric contraction would be tender as well. And again, if you can feel the palpable bursa, maybe in the shoulder, the hip, or the knees, you may be able to find that tender spot. And finally, I want to differentiate this to arthritis, and you're going to hear a lot more about arthritis today. But in arthritis history, you will get pain with active motion. So when you're using the joint, it hurts. And the weakness with arthritis is usually only as it relates to the pain associated with it. There also may be a history of morning stiffness. It takes a while to get going, to move the joint, to lubricate the joint until it's functional. In this case, on exam, passive range of motion is going to be as uncomfortable as active range of motion. So both will be uncomfortable. When you do isometrics and just contract a muscle near the joint, that won't hurt because the joint isn't moving. If you feel the joints, if it is osteoarthritis causing the pain, there may be crepitus that you can feel. If it's an inflammatory arthritis causing the problem, there may be a joint effusion present. So now we're going to go through head to toe different regional pain syndromes focusing on the soft tissue components. So starting with the shoulder, let's think about what the shoulder looks like. Here we have the humeral head sitting in the glenoid, and then you have these rotator cuff tendons that are holding this all in place. There are 4 different rotator cuff tendons: supraspinatus, infraspinatus, subscapularis, and teres minor, all wrapping around. You have the acromioclavicular joint up here. The acromion can sometimes put pressure on this rotator cuff and cause symptoms. There's also the biceps tendon that runs down the front. And what is not shown here are bursa structures. Sometimes we can see bursa structures on other imaging studies, such as an MRI here. You may see fluid within the space, which correlates with their pain. But generally speaking, we'll talk more about this. MRI is not necessarily that helpful in the initial evaluation of musculoskeletal soft tissue syndromes. So common causes of shoulder pain. There are many. So the most common thing I would say is rotator cuff tendonitis. As I mentioned, there are many different rotator cuff tendons. These, over the course of your life and overuse injury, a repetitive trauma, can develop microscopic tears. They can become impinged under that acromion and get further damaged and be painful and tender. You can also get calcifications that form within the rotator cuff tendons and cause a calcific tendonitis. This actually tends to be very painful. And on an X-ray image, you may see a little fleck of calcium right where that tendon insertion site is. There's also bicipital tendonitis, which tends to cause pain more in the front part of the shoulder, okay? This would be contrasted with bursitis. So there are several different bursas around the shoulder. The most common is the subacromial, right under the acromion, and then subdeltoid, which is a little bit lower. These can also be sources of soft tissue pain and quite palpable, which it can be helpful on your physical exam. You could have adhesive capsulitis. And in adhesive capsulitis, it can be caused by chronic rotator cuff tears or injury where you develop fibrosis of the joint capsule. And in this, the joint will not move. You will have limited range of motion. The patient will not be able to pull that arm all the way up above their head. They only get it this high. And so this would be another common cause if you were feeling restriction in range of motion and pain, but maybe no crepitus or something else, then maybe you want to be thinking about adhesive capsulitis based on the history. You can get arthritis in the shoulder joint itself, and it's quite common to see arthritis in the acromioclavicular joint, although it doesn't often cause much symptoms. The AC joint really is responsible for moving your arm across your body, and that's not one of the more typical things that people do repetitively. Other interesting causes of shoulder pain would be neuropathic causes. So you can have a cervical radiculopathy that's causing pain that goes down into this sort of shoulder scapular region. And so if there's shoulder pain that's not behaving like it should, maybe it's coming from the neck, not from the shoulder. And notalgia is another form of nerve pain that can localize to the shoulder, actually behind the scapula. You can get this sort of itching neuropathic type pain caused by arthritis in the thoracic spine. And sometimes the itching is so severe that you actually will get skin changes and browning of the skin in that area. From the history, you should be able to tell if it's a dislocation or trauma causing the shoulder pain. And then you also want to think about shoulder pain that may be referred from somewhere else. Maybe there's a cellulitis. Maybe there's a pneumonia that's causing referred pain to the shoulder, or cardiac issues that are causing, again, referred pain to the left side. On an X-ray, I mentioned before, sometimes X-rays can be helpful. You can see calcific tendonitis. What I'm showing here is chondrocalcinosis. So right here, you can see this thin white line on top of the cartilage. And so when you see this, you might want to think about crystalline disease, calcium deposition disease. And then also you can commonly see osteophytes at the acromioclavicular joint. So what can you do about shoulder pain? Physical therapy can be very helpful for healing some of these rotator cuff injuries. Systemic steroids are sometimes needed. Non-steroidals are available, oral and topical. You can also inject these areas. You can inject the joint, you can inject a bursa for pain relief. If there's a specific disease that's causing it, you want to treat that. For example, if it's a crystalline disease, maybe colchicine would be the right treatment. And then MRI imaging is generally not indicated for diagnosis, but is often used to guide surgery. Is there a complete rotator cuff tear? Is there something that they need to know before they operate? So when you inject, you could think about a subacromial approach. or a posterior approach. And the nice thing about the shoulder is actually the shoulder joint space is quite large. Here's an arthrogram, and you get an idea that even if you get it near the shoulder, likelihood is you're going to get some positive benefit from the patient. So let's move down further. So now to the elbow. One of the most common causes of soft tissue pain at the elbow is epicondylitis. And this is actually an enthesis where the tendon is inserting onto the bone. Most commonly, you see lateral epicondylitis or tennis elbow, but you can get it medially as well. Golfer's elbow is another name for that. You can get olecranon bursitis at the elbow, which causes some swelling there. And arthritis is actually quite uncommon. It's something you want to be careful to do when you're examining patients is make sure that there is full range of motion of the joint. And so if there's limited range of motion of the joint, it suggests an arthritis versus if they can extend and move, but there's tenderness locally, then it says that it's a soft tissue structure. So as I mentioned, this lateral epicondylitis is really an enthesitis. You've got these muscles in the forearm, and then they are sort of inserting tendinous insertions laterally, and you get this tender area on the outside part of the elbow, which you should be able to reproduce on examining the patient. Treatment of epicondylitis, I would have the patient think about what is causing it, what activities they need to modify. Maybe they could use a strap or a brace as shown here when they're doing those activities to help prevent the friction. Physical therapy can be quite effective in helping to heal these injuries, and injection can be considered if it's severe, but I will say I have hesitation about that. There's a study from JAMA from 2016, as I mentioned here, of 165 subjects with chronic lateral epicondylar pain, and they showed that there was improved pain at 1 month after an injection, but there was a higher recurrence rate and worse outcomes at 1 year in those patients that had the injections compared to physiotherapy. So I would really hesitate to do the injection because it may make this more of a chronic thing. Although it helps in the short term, it may not be the right thing in the long term. Here's a picture of an olecranon bursitis. Here's the soft tissue fullness. You would be able to feel it as you're touching it. It may be warm. It can be red sometimes, depending on what's causing it. You can get blood forming in here. You can get pus in here from infection. You can get crystals from gout or pseudogout. In order to figure out what's in there, sometimes it can be helpful to do a diagnostic aspiration, which you would do this direction. You don't want to stick your needle in this way. You want to go in from the side to take the fluid out. And that would be done for diagnostic purposes. Sometimes these things, and actually most of the time, these will dissolve on their own. So you don't have to remove the fluid. If you can prevent the patient from repetitively injuring it and banging it, for example, on a desk, the body will eventually resorb this on its own. I do recommend against injecting this with steroids. So things you can do for elbow pain. Physical therapy, again, can be very helpful for some of these chronic injuries. Steroids, depending on what type of process is causing the inflammation, or non-steroidals, again, topical is an option. You can do colchicine if it's a crystal disease. If it's an infected olecranon bursitis, antibiotics would be appropriate. But steroid injection of the olecranon bursa should be avoided. There's about a 10% risk of infection. You can also develop a chronic sinus tract. So I really avoid injecting anything in, although you could take fluid out if needed. So moving to the wrist. Common causes on board exams about wrist fractures would be a Colles fracture, a fall on an extended wrist. You can certainly get all kinds of arthritis, crystalline, rheumatoid, osteo in the wrist. But syndromes that can affect the wrist include carpal tunnel syndrome, a median neuropathy, and de Quervain's tenosynovitis. So carpal tunnel syndrome is often seen in middle-aged patients. They can be overweight. They may have comorbidities such as diabetes, thyroid disease, and there may be a history of overuse or misuse of the wrists. Often there is nocturnal pain and numbness in a median distribution, which involves the thumb, index, third finger, and sometimes the fourth finger. On physical exam, you would have a positive Tinel sign, tapping on the wrist, and Phelan sign. If you have the patient sort of really flex the wrist, you can again pinch that nerve and reproduce the symptoms. While you can do nerve conduction studies to formally diagnose this, it's often really only needed if you're considering surgery or trying to confirm your diagnosis for other reasons. Therapeutic options for carpal tunnel syndrome include rest, trying to avoid the activity that caused it. Splinting, particularly nocturnal splints, can be helpful. Steroid injections can be quite beneficial as well. I have a review down here about that. And sometimes surgery is necessary to really open that up and prevent the nerve from being pinched. Here's some example of supports that you may offer your patients in terms of ergonomics to improve their repetitive injuries, to make sure that they have good alignment of the wrist. And then here's an example of a splint that they can use. And then de Querva's tenosynovitis causes pain at the radial side of the wrist. So sometimes patients will say it's wrist pain, but it's really thumb pain. And it's caused by inflammation of the extensor pollicis brevis and or longus tendons along the thumb. What you have the patient do is a Finkelstein's test. You have them clasp their thumb inside their palm, and then you want to passively ulnar deviate this and feel along the tendon, and you're trying to reproduce the pain right there along those tendons. This is associated with repetitive motions of the hand and wrist, the most common being having a newborn baby where you're diapering, holding the baby down, changing clothes all the time, and really aggravating the tendons and overusing these tendons. Therapeutic options for this include, again, nonsteroidal anti-inflammatories. A thumb spica splint can be helpful to prevent those repetitive motions and rest the area, and then steroid injections can be considered. Moving down to the hip. We have bursas in the hip, the greater trochanteric bursitis being the most common that we hear about. There are multiple tendons, the gluteus medius, gluteus minimus tendons can all have tears that cause symptoms. And then there's this greater trochanteric pain syndrome, probably caused by a combination of these two, that just cause pain in the lateral hip. So this brings me to say that you should be careful when a patient says they have hip pain. They need to show you what they mean by hip pain, because it may not be the hip joint. It may be the lateral hip soft tissues. You can have a pulled groin, and there can also be arthritis in the hip joint itself, but that's usually going to cause anterior hip pain. And then there may be pain referred from the spine that is causing some of this lateral hip pain as well. So you want to think about lots of different surrounding structures. Here's an example anatomically of the spine. You have sacroiliac joints on the side. You have all these muscles that are supporting. And then here's your hip joints in here. And then this is the greater trochanter of the femur, where you have bursas on top of that. So these are the anatomical considerations when you're thinking about hip bursitis. And then as you're thinking about greater trochanteric bursitis, there are multiple bursa sacs around here as each of the tendons inserts on the lateral hip. Here you can see the gluteus medius muscle and a deep trochanteric bursa and some superficial ones. And these are where you can have the patient lay on their side and really mash on their lateral hip and see if you can find that bursa that's tender. You can inject that bursa. If you can find the area that's tender, you can offer an injection for pain relief. And so let's move down to the knee. So knee is really the first joint where routine plain films are pretty helpful. There's a lot of osteoarthritis out there, and having an idea of is there any arthritic change there before you think about soft tissue structures can be helpful. If there's a trauma history, you might think about a meniscal tear or ligamentous tear, or fracture. You can certainly get inflammatory or osteoarthritis in the knees, and there are several bursas as well, the prepatellar bursa right on top of the knee, and the pes anserum bursa, which is more medial. So thinking about knee anatomy, you have the patella sitting in the femoral groove, you have your collateral ligaments on the outside, and then as you flex the knee, you can then see the cruciate ligaments here, and then the menisci on either side. And so these are all areas that can be affected and cause knee pain. Here's an x-ray showing chondrocalcinosis, like I showed before in the shoulder. You can see this calcium deposits on top of the cartilage. It can be helpful when you're thinking about what's going on. Here's an example of knee osteoarthritis where you can see, significant loss of cartilage space laterally. You can see these big bone spurs medially and laterally. And this is pretty advanced osteoarthritis. If you have a patient complaining of knee pain and you see this, you're pretty sure that it's osteo and not going to be, even if there is some sort of meniscal damage, it's too far gone. Moving down to the ankle. Sprains are quite common in the ankle, this traumatic ligamentous tear I mentioned before. Fracture is something to think about. Osteoarthritis is pretty uncommon unless there's a history of repetitive injury to the ankle. Crystal arthritis is pretty common. That would be hot, red, swollen. And then tendonitis. There's lots of tendons in the ankle, and you want to think about the distribution of pain to figure out which tendons might be involved. So for lateral pain, peroneus longus and brevis. If it's medial, tibialis posterior, and the flexor hallucis longus, and then anterior tibialis anterior tendon. You can also get a neuropathy of the ankle, a tarsal tunnel syndrome, similar to carpal tunnel syndrome. Here's your anatomy, so you get an idea of the ligaments that help hold things in place. There's lots of little bones. You can get midfoot arthritis. There's lots of arthritic things that can generate pain, but I know we're talking more about soft tissues. So if there are sprains, you want to advise the patient to protect from further injury. Putting them in a boot may be very helpful. Rest, ice, compression, elevation, these help to reduce swelling and promote healing. Non-steroidal anti-inflammatories can be very helpful for pain relief, and then a gradual return to physical activity. So you want to consider physical therapy for most soft tissue injury. So the idea is that you want to treat locally any of these sort of things that, if the shoulder hurts, physical therapy first, and then you can evaluate if it's not getting better and refer them on. So now that I've talked about these local structures, let's talk about generalized soft tissue pain. Fibromyalgia. So I like to think about different types of pain. So you can think about mechanisms of pain. You can have peripheral pain due to inflammation, mechanical damage, those things we talked about in each individual location. You can have neuropathic pain caused by damage or entrapment of nerves, like the carpal tunnel syndrome, tarsal tunnel syndrome I mentioned. But then there's this central pain, which is non-nociceptive, so not necessarily related to injury to a nerve or to a structure, but it's a disturbance in pain processing. And so fibromyalgia is really the final common pathway of central pain. And I think it's helpful to know that, we all have various degrees of fibromyalgia. I love this quote by Dr. Clog, University of Michigan, that, all of us can have some degree of just sort of generalized tenderness to touch, but it's really when this is to a severe degree that we can call this fibromyalgia. So fibromyalgia is a pain syndrome diagnosed when pain is present for more than 3 months and has a sufficient severity and impact on the daily quality of life if they're seeking medical care. And generally, you want to make sure there's no medical cause for this. You may remember the tender points that you can press to kind of figure out if this is maybe what's going on. When you're thinking about diagnosing this, I think it's helpful to look at these criteria, these diagnostic criteria that were proposed in 2010. They asked the patient to consider over the past week how they felt, try to exclude pain from known illnesses or injuries, and you want to look at how much widespread pain there is and the severity of the symptoms. So here's an idea. You can have a patient circle here. How many areas where have they felt pain? How many, there's a scale between 0 and 9. If they've got, 9, 10 different things that they're circling on here, that's pretty widespread pain. And then you will look at the symptom severity. How is it affecting their quality of life? Are they having fatigue, waking up refreshed, cognitive symptoms like brain fog? And are these mild, moderate, severe? You can get a score again of 0 to 9 here. And then you also want to look at somatic symptoms. So often I have patients do a review of systems. If somebody is marking off every single thing on the review of systems, that's going to be a great deal of symptoms versus if it's just a few, maybe like some migraines and a few other things, and that may be a smaller score of 1. And you can put these all together to make a diagnosis. So if you have generalized pain in at least 4 out of the 5 regions of the body, symptoms have been present for at least 3 months at a similar level, there's widespread pain of at least 7 areas with a symptom severity of at least 5, or less widespread pain but more severe symptoms, and then you can call this fibromyalgia. And it really doesn't matter if there are other diagnoses like rheumatoid or lupus, you can still make this diagnosis. What you want to do is examine the patient. You need to feel these different areas, feeling around the bursas, the muscles. Sometimes just touching the forearm is tender. You want to make sure there's no joint swelling. You don't want to, rule out an inflammatory arthritis. Or you want to rule out inflammatory arthritis and make sure you're not saying that something's fibro when it's something else. You may want to check some labs, CBC, thyroid, inflammation markers, chemistries, muscle enzymes, vitamins. I try to avoid checking a rheumatoid factor or an ANA unless indicated, because sometimes it just gets you into trouble. Be very careful about considering the diagnosis of fibromyalgia in the elderly. It's usually more likely to be something like polymyalgia than fibromyalgia. And this is where the SED rate and CRP can be very helpful in distinguishing inflammatory versus non-inflammatory conditions. But it's nonspecific. CRP can be elevated from obesity alone. SED rate increases with age. A good rule of thumb is your age divided by 2 is your normal SED rate. And it can be normal in early systemic rheumatic illness. You may want to follow this over time. And it's never going to be diagnostic, but it will help support your differential diagnosis. The treatment of fibromyalgia should be multidisciplinary because of all the different things, the pain, the brain fog, fatigue, insomnia. You want to educate the patient about the condition, that it's a pain syndrome. You want to work on sleep interventions. You want to have them try to exercise. Maybe they work with a physical therapist to get started. Cognitive behavioral therapy can be helpful so the patients can sort of learn to live and cope with their symptoms. Medications, if they're not improving with non-pharmacologic treatment, can be tried, but I will say that the published studies of FDA-approved medications for fibromyalgia are only showing about a 30% improvement in pain. And sometimes the benefits, the pain relief is not worth the risks or the side effects in some patients. So they're not necessarily the cure-all for this. So in summary, soft tissue pain syndromes are among the most common reasons patients seek medical attention. A diagnosis is frequently evident after proper history and exam. You want to embrace the principle of local therapy for a local problem. And if there's generalized soft tissue pain, a multimodality approach may be required. So moving to our questions. Question 1, 55-year-old man with significant alcohol use, hypertension, and diabetes with a decreased GFR presents with a swollen olecranon bursa. Aspiration is performed and crystal exam of the fluid reveals monosodium urate crystals. Which of the following is appropriate at this point? Cortisone injection, NSAID therapy, or oral steroids? I think I'm just going to move to the answer at this point. So the answer is C. You want to avoid injecting into the olecranon bursa due to the increased risk of infection. This patient that I mentioned is at high risk for NSAID toxicity, and really oral steroids would be the least risky option. Question 2. A 50-year-old woman with a 1-week history of severe right shoulder pain. On exam, her shoulder moves normally, but due to the level of pain, a cortisone injection is administered. She comes back 1 week later with no improvement, but extension of pain down to her elbow. What is the most likely diagnosis? A, recalcitrant adhesive capsulitis, B, acute myocardial infarction, or C, cervical radiculopathy. Wonderful. So I agree with the majority here that cervical radiculopathy is the most likely explanation. The other two don't make too much sense. So finally, question 3, 32-year-old woman with rheumatoid arthritis on methotrexate complains of diffuse muscle and joint pain. She feels tired and isn't sleeping well. She feels like she's in a fog and is forgetting things at work. And this weekend, she was out in the sun and felt even more tired. On exam, there's diffuse soft tissue tenderness. There are no swollen joints and no rash. The question is, which of the following is the most appropriate next step in this patient's management? A, a trial of prednisone. B, check an ANA. C, add a biologic. Or D, amitriptyline and aerobic exercise. All right, we are interesting. So a little bit of spread here. So the correct answer is D, that you want to do a trial of amitriptyline and exercise. And the reason for this is that there's no joint swelling. I was a little tricky in the question here mentioning the sun, but there was no rash. It's just the patient felt more tired in the sun. And in this case, really the patient was basically telling you with their history that it was very classic for fibromyalgia. So that is what I have to present to you today about soft tissue syndromes. Here's some supplemental references if you would like, and I thank you very much for your time.
Thank you, Dr. Ritter. That was an excellent talk. There were a number of questions, and we will answer those during the Q&A session. Dr. Ritter will be back with us again at the end. Again, thank you so much, Dr. Ritter.
Thank you.